the phenomenon of anesthetic awareness. It feels like that would just be the worst possible thing that could happen to someone, is that they could have an awareness of the surgical procedure that they're undergoing and then not actually be able to communicate that. What is your understanding of that phenomenon? How common is it? And like what are researchers doing about trying to mitigate that risk?
It's not very common. It's somewhere between 1 in 100 and 1/10 in 100. It's fairly rare.
I hope not.
But but given that there are, a million surgeries a day, that still translates into a lot of patients, thousands of patients. What happens, anywhere from, mild irritation to full-blown panic and catastrophe, and making the surgery more difficult because the patients may have an autonomic response. Blood pressure will shoot up, heart rate will shoot up because they're experiencing pain and they're trying to tell anyone, help me, and they can't. The people who have the worst responses will also have post-traumatic stress syndrome on top of that, where they could have nightmares for weeks or months. Afterwards, they'll have to seek, psychiatric or psychological help to try and get through that. So that's probably the worst case scenario. I don't think, people don't die from it, but it can be very debilitating to certain people.
All right, cool. Let's start with the general anesthetic stuff. So what is unconsciousness?
To anesthesiologists, we have it easiest of all because we just have a behavioral measure. So the early stages of loss of consciousness, you just can't respond when I say, "How are you feeling, Paige? Are you okay?" Then it goes a little deeper when you can no longer respond to commands for volitional movement. So, for example, I might say, squeeze my fingers. Normally you'll respond with a squeeze, but eventually you'll stop responding. So that's a pretty deep level of loss of consciousness, a little beyond sleep even. And then there's the surgical definition of loss of consciousness, and that's having no recall of the experience of surgery. And that also is influenced by strong stimuli, painful stimuli. Like anesthesiologists have it pretty easy. If the patient can move, then they're not unconscious. And I think in the more common use of the word of consciousness, I think even our daily sleep, most of us would consider we are unconscious.
It sounds like there's sort of like a continuum of conscious, of all the way from being conscious down to being sedated, down to being unconscious. And then along that continuum, there's these different plots of, like your inability to respond physically, your inability to respond verbally. And then there's kind of like sleep is somewhere in there, but it's also sleep is different to being under general anesthetic. And then right at the very end of the spectrum is even when you're having your chest cut open and your organs manipulated, you can't feel it, and there's the inability to form memories, which is what I'm really interested in. Is like, how is it that when we get down that continuum, and right towards the general anesthetic end, how is it that you're not able to form memories of of what could only be described in some surgeries as like full massacre to your body?
Well, that's actually being looked at pretty intensely, and we're starting to get a pretty clear picture of what happens at that stage where you can no longer form memories. And it's turning out to be a direct anesthetic effect on inner neurons that control the activity of hundreds or thousands of the pyramidal cells that we think are critical for forming the engram circuits that store memories. So the way that works is the inhibitory interneurons appear to get depressed by anesthetics in a way that then prevents them from releasing inhibition of other interneurons that would normally inhibit the pyramidal cells. So it's a little more complicated than we were
Mm.
hoping. In the beginning, we were hoping, oh, you just depress the pyramidal cells and the excitatory inputs to them. And so those synapses can't undergo plasticity, can't strengthen themselves, and hence store the information. And that's still true downstream, but the upstream cause of the effect is a block of disinhibition by enhancing inhibition of a certain group of GABAergic interneurons that then control other groups of interneurons that control the pyramidal cells. So, and I'm sure, the final story will even have more twists and turns, but right now that seems to be the general way that anesthetics disrupt learning and memory. About half the surgeries in the United States involve monitoring EEG activity in the frontal cortex. There's a lot of variability among patients. It's often hard to get a good, clean EEG signal in the operating room because there's a lot of electronic equipment that can interfere. Seems to remain the most promising approach is using a combination of brain monitoring and preferably with some sort of stimulus to to raise your awareness to the kind of level you might respond to pain with. But that's rarely done. Many years ago, they tried visual stimuli and auditory stimuli. They work pretty good. So you can do brainstem auditory evoked potentials, for example, during surgery. The problem is not all anesthetics and all people exhibit the same responses. Patient variability is amazing. Everybody thankfully can be anesthetized. The difference in level of drug administered can be fivefold from someone who's super sensitive to someone who's very resilient.
It makes me wonder, for the people that experience the most horrific versions of anesthetic awareness and are basically like fully cognizant for entire open body surgeries, it makes you wonder like about what pain actually is. And I want to take the opportunity to talk to you about this because this is an area of your research at Stanford. You often think that you could die from being in so much pain. Is pain far more subjective than we give it credit for?
I'm guessing that it's a subjective experience and non-life-threatening. However, the consequences, increased blood pressure, increased heart rate, could have life-threatening effects through heart attack, through stroke, through all the things that can go wrong if your brain doesn't get enough oxygen. Could you die from pain alone? I think not likely. But through a secondary effect, if you had heart disease or a blockage somewhere, it could be exacerbated.
Often, like when I have conversations with people about things like death, I hear like, I'm not afraid of death, but I'm afraid of the pain that might precede death. So people tend to have this like really extreme fear around pain. And I wonder if that's because it's connected to a fear of death as well, or it's like connected to a fear of having to have like a really intense and extreme experience.
Interestingly, when you talk to people about their fears of anesthesia, it's more about memory than it is pain. Fortunately, in modern medicine, pain is dealt with separately from the anesthetic, usually with an opiate analgesic. That's going to really blunt your subjective experience of the pain. The anesthetic on top of that will diminish the intensity of the painful stimuli that's getting up to the conscious level in the brain. Patients will complain about other things they experience during the surgery. So a common example is voices and things people were saying and sounds in the operating room, like drills and saws and stuff like that. People will complain more about that. Rarely do they complain about pain.
And we kind of talked about this before, but there is a big difference between sleep and unconscious.
That's exactly correct. And there is a big difference between how you become unconscious in terms of restoring a sleep debt. So that's been looked at fairly carefully in people and animals. And anesthetics in general are not a replacement for natural sleep. You
Mm.
don't allow your brain to go through all the machinations it must go through to store memories and to put things in context. And there's one anesthetic that seems to be okay for this, and that's dexmedetomidine. It acts through a really unique mechanism on alpha adrenergic receptors in the brain. It does produce more of a natural sleep and can reverse sleep debt that's been built up by, they do these sleep tests where they can keep animals or people awake by poking them and waking them up to cause a sleep debt. So they interrupt their sleep rhythm so they can't go through all the stages that they need to make a healthy
Oh
brain.
my God, that just sounds like my second worst nightmare. First worst nightmare would be anesthetic awareness. Second worst nightmare would be poked and prodded and not able to get into REM sleep.